Welcome. I'm Renee Pinsky, Assistant Professor of Radiology at the University of Michigan in Ann Arbor, Michigan. I'll be talking today about screening for breast cancer. This is information for primary care providers in Michigan. This section will be divided into three modules. The first module will be discussing the agreement over screening mammography. Screening mammography reduces breast cancer mortality. The second module will be addressing controversies in screening, and the third module will be discussing the negative consequences of screening. The agreements over screening section will have the intended learning outcomes of the following: to be familiar with the extensive research demonstrating mortality reduction resulting from screening mammography, and to counsel patients regarding the utility of mammography, including evidence for mortality and morbidity reduction. The outline for today's talk is screening mammography introduction, breast cancer mortality rates, scientific support of screening mammography with regard to both the randomized controlled trials, the observational studies, and computerized models that are used to address screening mammography. Screening mammography in average-risk women has the purpose of decreasing mortality and morbidity from breast cancer. The goal is to detect cancers at an earlier stage than would be clinically apparent. The other goal is to allow more limited surgery when it is diagnosed and more limited medical treatment for the disease. Screening mammography is performed in asymptomatic women. Breast cancer mortality has been declining in the United States since the early 1990s. The implementation of screening occurring in the late 1970s and in the 1980s. The decreased mortality over these years has been approximately 35% in the years from 1990 to 2011, and that is felt to be related to both screening and treatment, an issue which will be discussed later in the talk. There is an even greater decline in the mortality rate when you look at the increasing trend of breast cancer deaths, which was occurring in the mid-90s, and it is apparent with the red arrow shown there. The randomized controlled trials were performed in the 1970s through the 1990s, and these are relatively old studies. However, they do form the bedrock of mammographic screening science. These are studies that were performed with women who were either invited to screening trials or they were not invited and they were considered to be given standard of care at the time. So they were invited to screening mammography sessions. Whether they attended the sessions or not was a variable event. There was in these studies the ability for women in the control arm, meaning the women who were not invited to screening, to get screening on their own in the community. And so there was some contamination of these studies when they were performed. There were variable mammographic methodologies employed for these various studies. There were differences in age range, differences in the frequency of screening. Some were screened at 12 months, 18 months, or 24-month intervals. The number of rounds of screening also varied from study to study, and the length of follow-up varied from the studies, varied within the studies. There are, however, taken in general as a group, and their outcomes are analyzed together. Marmot in 2013 published this review of the randomized controlled trials, of which you see 10 studies here. And the outcome of this review showed that the relative risk of breast cancer from the randomized controlled trials was 0.80, which represents a 20% reduction in breast cancer mortality for the women who were invited to screening. This was considered to be a significant improvement in outcome for these women and led to the implementation of screening in the populations. The randomized controlled trials generally reported their results at approximately 8 to 10 years after implementation of the studies. There were, in addition, 2 studies that were followed for a long-term period. One trial was the Swedish 2-county trial, which was followed for 29 years after mammographic screening. And this demonstrated a 31% mortality reduction in relative risk of breast cancer for women who underwent screening. And what's interesting to note is that these are the curves of the women, the cumulative mortality on the y-axis and the time since randomization into the study on the x-axis. For the women who were invited to screening, their mortality was significantly decreased by the 31%, as I described previously. However, the decrease actually was most apparent after 10 years of screening, when these curves begin to diverge. So it's very important that when looking at breast cancer follow-up studies and mammography follow-up studies that they be carried out for at least 10 years to show the benefit of mammography taking place after the first 10 years of follow-up. The Canadian National Trial was actually 2 studies within the randomized control set, and this these 2 studies underwent 25 years of follow-up. These studies did not show mammographic screening to decrease breast cancer mortality, which was similar to the original study, the earlier reports from the Canadian National Trials. These studies were 2 outliers of the group of randomized control trials, which did not show breast cancer mortality reduction related to screening. The observational studies that have been performed more recently, these are more up-to-date trials than the randomized control trials that were performed in the 70s and 80s, similarly demonstrate a significant reduction in breast cancer mortality related to breast cancer screening with mammography. In this study of multiple observational trials, there's a demonstration of approximately 49% mortality reduction. These are the overall mortality reduction related to mammographic screening, and this was reported in 2012. These were predominantly European studies, and they did represent various ages of population, including screening starting for women in their 40s as well as starting in their 50s. So this was a mixed group of women, and it showed a very significant decrease in mortality when women were screened for breast cancer using mammography. Similarly, a study performed in Canada in several different Canadian provinces demonstrated a 40% mortality reduction related to mammographic screening in this very large study, which included approximately 2.8 million screening studies, including women ages 40 to 79. And when they broke it down by decades, all ages benefited from the mortality reduction demonstrated here. There was no stratification by age. The computer models that have been used to evaluate mammographic screening efficacy include CISNET models. This is data that was taken from the USPSTF analysis from their 2009 analysis and recommendations. And this was reanalyzed by Hendrick and Helvey in 2011. And this was mainly showing that there was a difference in biannual screening versus annual screening, and that's what's denoted here, and differences in the age groups screened. But what I'm trying to point out here is that even in the biannual group, women ages 50 to 74, or the annual group ages 40 to 84, there was a significant mortality reduction in these groups compared to women who were not screened. Screening did result in a larger mortality reduction in the women screened annually over a broader age range, but even in the group starting at age 50, there was a mortality reduction related to mammographic screening. So the issue has come up. Mammography, we know that it does improve mortality. It does result in mortality reduction, but how much of that is related to mammography versus medical and surgical treatment effect? So that has been addressed, and this was a study published in the New England Journal of Medicine in 2005 looking at the effect of screening, mammography, and adjuvant therapy on mortality for breast cancer. And the graph that you see on the left demonstrates the curve of the rate of death for women who do not undergo screening and who do not receive adjuvant therapy. And clearly the death rate is increasing over time as time goes on. With the advent of screening and adjuvant therapy, their individual effects are noted here. When combined, they result in a significant decrease in the death rate from breast cancer. The issue here is that there was a very low compliance for mammography in this study population, and so this was further evaluated, which I'll discuss in just a minute. What's important to note here is that even with a 50% compliance rate, there was a 46% reduction in mortality, which was attributed to mammographic screening. So the effect that mammography is having on the overall reduction of mortality is significant. In a study performed and published in 2014, this was a computer modeling study that looked at 100% compliance with mammographic screening to determine how much the effect was related to mammography versus medical therapy. And the outcomes for all cases of breast cancer, which are listed here, demonstrate that 74 to 69% of the reduction in breast cancer mortality was related to annual screening as opposed to screening plus medical therapy afterwards. So a significant amount of the improvement in breast cancer mortality is related to mammography. The morbidity related to breast cancer is also very significant, and it's something that is less frequently studied than using death as the endpoint. But in the 2007 study looking at the outcomes of participation in screening mammography and the effect on subsequent need for chemotherapy or the subsequent ability to have breast conserving therapy as opposed to mastectomy, demonstrated that women who underwent screening were significantly less likely to need chemotherapy and significantly more likely to be eligible for breast conservation therapy than women who did not undergo screening mammography, rather whose cancers were diagnosed clinically. Another study that was published in 2012 had a similar outcome. It showed that looking at women in the age range of 40 to 49, what their results were in terms of need for mastectomy versus use of, as well as the use of chemotherapy. And the women who were screened had a significantly lower need for chemotherapy following their definitive surgery than women who presented with symptoms and had their cancers diagnosed clinically. Similarly, their need for mastectomy was significantly lower if they had undergone screening versus women who presented with symptoms. So mammography not only decreases breast cancer mortality, but also decreases morbidity once the diagnosis is made. So I've concluded discussing the use of the science behind screening mammography and why it's performed and the reductions in breast cancer mortality and morbidity. And we're going to now move on to controversies in breast cancer screening with mammography.